Just one announcement before I get going. I sent this, I forwarded an email to Katie, and all of us may remember our friend, the pain psychologist. He just wrote a book. Katie, did you see that email that I sent?
Yes, I did. Yep.
Yeah, Murray McAllister passed away a while back, and apparently he was in the process of writing a book about the treatment of chronic pain, and the book is coming out very soon. So if you want any information, you can contact Katie, and she can send you the information about they're having a virtual kind of a thing about his book. Charlie, I don't know if you got that as well, but I can forward it to Charlie if you would, Katie, and if anybody else wants it, just messages. It says the book was about. Can you read that thing, Katie? It's I can't remember exactly how it says it, but
Here, I can.
Okay.
It says. Sorry, I'm bringing it up right now. It's called "How to Have Hope When There Is No Cure: A Comprehensive Guide to Chronic Pain Rehabilitation."
Yeah, written by our friend Murray McAllister, who tragically passed away this year. So they still published his book, so it's just coming out. All right, so today we have Charlie on, and he's going to be talking about substance use disorders in the palliative care setting, which is, I just can't wait to hear what he's got to say. It could be kind of interesting. Remember, there's a new echo format coming, and you'll need to register for the iEcho. Just remember that. It takes about 1 minute and 9 seconds. And where'd that picture come from? Oh, that's one from Stratus.
Yep. Katie will be sharing the link for that at the end of the session. So make sure you check that out. It's very quick and easy.
Yeah, you can skip through these next 3. We already did this. But upcoming echo sessions, again, next week is a really interesting talk on nutrition and a pathway to recovery, which I think is going to be great. And then a guy that talked at ASAM on buprenorphine for chronic pain, which I think we can all appreciate as well. I actually had a call yesterday from somebody who wanted to know about using it for chronic pain. So this guy's a great speaker too. So it should be a great talk.
Awesome. And please send recommendations our way if you encounter any phenomenal speakers at conferences that you attend. We would love to, get some fresh speakers and check people out. And then there are free CMEs for the echo sessions.
Yeah, just make sure you turn on your video if you can, because Charlie likes to talk to people. Remember, if you have any questions, just give us a call. You can just give us a ring, and we're happy to help out. We can't obviously particularly give you patient advice if we don't see the patient, but if there's situations you want to ask us about, we're always happy to help. So, and now on to Charlie.
Okay. I'm going to make half of you want to disconnect by declaring myself a Packer fan. There's this Packer who this weekend played on offense and got a first down, on defense as a cornerback, and on special teams receiving a punt, receiving a kickoff, and defending a punt and defending a kickoff. He played in every phase of the game. Keyshawn Nixon. Anyways, wow. I'm impressed with him. I feel a little like him today because I'm doing inpatient consults and outpatient clinic, and I'm on call for the methadone clinic, and I'm doing everything at once, and I am definitely less composed than Keyshawn Nixon normally is.
But yeah, Charlie, just so you know, anybody who says yay Pack, we're going to just disconnect them too.
Oh, yeah.
There were a couple of them in the chat. I'm trying to switch them down.
Yes. So that is a very Wisconsin way of, and that's a humble brag way of saying, forgive me if I'm a little disjointed because I got a lot going on today. But I am also very excited to speak with you. And I was hoping that this could be interactive. And so I'm going to ask some questions of you all. I mean, I have the things that I want to say, but instead of just saying it, I'm going to slightly challenge you to either unmute and talk or enter things into the chat. I assume that most of you are in the sort of more in the addiction oriented spectrum than you are in the palliative care spectrum, but I may be wrong, and there may be some palliative care providers here that bring their own experience, which would be excellent. And I assume there's also some primary care clinicians or people in primary care clinics here who straddle both worlds. So let me make sure that this final, yep, okay, we're good. Okay, so I'm going to talk about substance use disorders in the palliative care context. Okay. So yeah, I'm going to, look at the definition of substance use disorder. I'm going to think about how that interacts with palliative or end-of-life care, discuss pain control with some of these patients. And then if there's time, we'll talk a little bit about buprenorphine in the palliative care context. So I think a lot of you know this and have seen this. So we don't need to belabor it, but I'm saying this for a reason. I'm going to give you next the criteria for substance use disorder, but obviously, depending on how many criteria you meet, you have mild, moderate, or severe. And here are the criteria. And this is one way of, this is probably the traditional way of looking at it. Here's another sort of way of looking at it. And I'm just going to pause here for a second. I think we all have our preset stereotypes or notions about what substance use disorder looks like. And it's probably not just one thing, but we probably have seen a variety of different ways that substance use disorders manifest. And when we think of use in larger amounts over longer periods than intended, we kind of have a concept of what that means. And if we think of failure to fulfill our role obligations, home, work, school, I think we kind of have a concept of how addictions cause that. If we think about like important social, occupational, or recreational activities given up, we know what we're talking about. So like a lot of us who've used this criteria and applied them to people, we've seen how this criteria translates into real life, and we have a sense of that. But the reason I'm pausing here is because I kind of wanted to ask you to imagine for a second that we're applying these criteria not to real life, but to someone at the end of their life who's, let's say, they're dying of metastatic cancer, and we're prescribing them opioids and they're dying of metastatic cancer. So my question for you is, if you could put it into the chat, or if you want, you can unmute and sort of try to apply one of these criteria to a human being at the end of their life who's in palliative care, in hospice, getting opioids for cancer pain. How might that criteria look different? Does anybody have a sense? Does anybody want to share a sense of how this criteria might manifest, how addictions manifest in the end of life? I love the pauses because it allows me to sip my coffee. So Sarah says, less concerned about reducing use of opioids or setting limited time on opioid duration. So yeah, I mean, there's probably a lot of ways, and those are great examples of how they manage their opioids. So managing opioids in a way where they're not minimizing opioid use or minimizing time of opioid use. What else? Anybody else want to give any? So how might that affect any of these other criteria? Okay, great. So I had a cancer. I'm quoting here. Oh, we got a couple. I had a cancer patient who kept asking for more and more and claiming it wasn't helping, but not willing to wean off or do something else. So it interferes with our ability to sort of interpret their pain report and can cause fraught interactions with the clinicians who aren't really sure how to make sense of it. Someone else says, I'm helping to care for a patient right now with severe opioid use disorder and metastatic rectal cancer, and he was found to be eating his fentanyl patches and he doesn't understand why his team's concerned about it. Or in fact, part of him might understand why there's concern, but he's also feels immune to concern because he's got metastatic cancer, so back off. So those are great examples.
It's funny, Charlie, because often, and I can think in the past, where people would be very, very careful with how many opioids they gave people because they thought they were going to commit suicide.
I had not thought of that. That is a really interesting point. And there are and the opioid user, the person with opioid use disorder or addictions, and the person with metastatic cancer or other life-limiting illnesses, they're all separate risk factors for suicide. So suicide is a really interesting concept to think about here. I will list some, if there are any others, I can list some things that I want to draw your highlight attention
So,
to.
Charlie, this
Yeah.
is Sarah. I'm thinking about this more specifically. And, someone towards end of life, they maybe not be that concerned about their role obligations, right? Like their priorities might have shifted dramatically. And that was one point.
So I'm really glad you said that. So my question is, what does it mean to have a role obligation at the end of your life? And how does that change? And maybe what that means, maybe there's legal paperwork that needs to be signed. Maybe there's communications or wishes that need to be stated. Maybe it's different types of roles. It's like a role that probably none of us planned for, but it is a role, and it has all these different functions that people at the end of their life do. It's not work, home, or school, but and I'm experiencing this with my parents who are in their 80s and are both nearing the end of their life. And they have all these things they need to do, but they're totally new to them. So they're learning new situations. They're making new types of decisions. They're communicating with their family in new ways that they haven't done before. And the problem is that it's already hard enough to do that. But if opioid use disorder is interfering with your ability to sign the legal documents, plan your wishes for your estate, communicate those things to your family. I mean, there's no obligation to a person to do that, but it is kind of their role, maybe, arguably. I don't know. How do you take that, Sarah?
Yeah, I think that's a valid point. It helps shift it. I mean, the other area my brain goes to right away is the emotional aspect of pain. And in that situation of nearing end of life, how much fear and anxiety drives the pain. And also the, anxiety around having uncontrolled pain too.
Yeah, and I think you're right. And I think, oops, I don't know if you guys can see my epic. So I think you're right. And I think someone else mentioned, and maybe I'm misunderstanding it, but it was almost like their own medical care and managing their pain and managing their relationship with opioids and their palliative care team is kind of their primary role at this point. And they're managing their own medical situation. They're managing their own death is their primary role. I mean, maybe some patients don't want to do it, but even choosing not to do it is kind of a choice. I just quoted a rock band, but my point being that and then your point about emotions and grief and suffering, we're going to get to that later. So
Charlie, I don't know if you saw the other. There was a couple other chats.
Okay.
It said all other goals of care take a backseat to pain management and relief.
Is that true? I mean, maybe. I don't think that's true for everyone. I think that should be a patient-centered choice. And I think someone perhaps at the end of their life who's in pain should have the option to make that choice.
Yeah.
But I think there are probably a lot of stoic old folks where thinking is being awake is probably, and being in control may take precedence over being pain-free. I think that's an individual choice, but I think it's certainly a valid choice for those who make it. That's my opinion.
Yeah.
What else? Was there another one?
Yeah, there's one about what type of cultural considerations do you think there would be as well?
I'm gonna mention one cultural consideration. Sorry, I don't know if you're seeing my epic pop up. I think I
No.
fixed it. I'm gonna mention at least one cultural consideration, but that's a super good point, and I'd love later when I talk about my cultural consideration, I'd love to hear that individual's thoughts. So here are some of my concerns. I think it's important that there are other coping mechanisms besides opioids. I think people with opioid use disorder might over rely on the substance for coping. And in honor of Murray, who I'm sure would be, I mean, he would be cautious in referring to this to the end of life care, but I think even in the end of life care, maybe until the very end, there are more coping mechanisms than just opioids. But I think there's a risk with opioid use disorder that they over rely on opioids. And then loss of control over, they're going to have traditionally, I don't want to say unfettered access, but much greater access to opioids and much fewer barriers to opioids. And then if they lose control over those opioids, that could be a problem. And then, using to the people with opioid use disorder and access to a lot of opioids will use to the point of oversedation or even respiratory suppression, which doesn't need to be a bad thing at the end of life, but it could be based on the wishes of the individual. So it all depends on the wishes of the individual. If it is appropriate for them, respiratory suppression and sedation could be totally perfect, fine. But if that's not their wish, and then the addiction intervenes and they can't control themselves around opioids and they end up oversedated when maybe it's not appropriate for their own personal intent, that would be a problem. And I think this is an issue, and we're going to talk more about family later, but anyone with opioid use disorder with access to a lot of opioids might end up using opioids instead of family or health. And by health, I don't mean you're going to magically be cured. I mean, what is your wishes for your health at the end of your life? And how do we optimize those wishes? And then what are your wishes for your family at the end of your life? Whatever that means to you, family. And how do we optimize that? And unfettered access to opioids might interfere with that. And then as I mentioned earlier, I do think that there are roles at the end of life. I am witnessing that with my parents. And I think to the extent that the patient wants to fulfill those roles, opioids might interfere with them. My parents are especially my dad is very aware of what his legacy will be. And my mom as well, in a different way. And that's kind of one of their primary tasks of their own doing is to think about what happens after they're gone. And I think it's important that people have that opportunity if they want that opportunity. So, and then my next question, just to be provocative, is I believe that there are some ways in which palliative care clinicians are totally equipped to handle patients with addictions and actually have a lot of things in their favor in these situations. And I think there are also some ways in which I don't want to say they have blind spots, but they have some weaknesses or lack of training that might hamper them. So I wonder if there's some chats. I'll read the chats, but while I'm reading the chats, if anybody has any thoughts or reflections on what strengths do the palliative care team have in handling these patients, and maybe what weaknesses they might have in handling patients with addiction at the end of their life. This is just, I want to hear your thoughts. I'll read the chats that are there though. Ooh, psychedelics. We'll talk about that.
Of course we will.
Yeah. Valerie, I like your comment. I think Valerie's comment about relationships is on point. Got it. And Daniel makes a really great clarification about coping mechanisms. Wow. So it's interesting, Yolanda, if you're comfortable, maybe share a little more about how you have seen patients with opioid use disorder be stigmatized by the palliative care team. I think this is an area of evolution for palliative care. We'll talk some of the reasons why that's the case, but I don't want you to throw anyone under the bus, Yolanda, but if you're comfortable, is there any way you could describe more on what kinds of stigma or how you're seeing stigma play out in patients with opioid use disorder? And then we can move on. I'll say if Yolanda chooses to answer while she's thinking about that, I think palliative care tends to have time and tends to be good at being aware of patients' own goals, patients' own wishes, and not projecting the clinician's wish onto the patient. But they have time, they listen, they're patient-centered, they can be flexible in terms of the treatment plan. They're probably very holistic in terms of the home environment, the resources at play. They're very creative in terms of pharmacology they can use to manage symptoms. So I think all of those are incredible strengths. I also think that in a palliative care setting, maybe I'm estimating 90%, 95% of patients interact with opioids a certain way. And people with opioid use disorder interact with opioids in a very different way. And so they may get into the sort of routine of a certain type of patient, the vast majority of patients who interact with it, and that may not be fair. I think also there is something, and Kurt, you can correct me, in addiction medicine, sometimes you have to say no. You have to set limits. And that is inherent to addiction medicine. You have to say no. You have to set limits. You have to be not patient-centered, but a little paternalistic, if that's the right word. And I'm not sure that's the strength of the typical palliative care clinician. And that is not an insult. It is not an insult. But I just think there are some instances where people with addiction, they need to hear no, or they need limits that are hard limits. And addiction doctors, addiction clinicians tend not to be as afraid of conflict and can sometimes even just walk into a conflict. They know it's going to happen, but we got to do this. This is going to be uncomfortable. And I think that sort of experience with conflict with patients and setting limits with patients is probably more the addiction doctor's strength, clinician's strength, and less the palliative care clinician's strength. I may be wrong about that, but that's my editorial on the difference.
I think it's interesting, Charlie, that often the patients that we see are kind of, in a way, pharmacists, right? And so they'll come in with these ideas of what they think they should be doing or medications that they think may help. And they come in with these things, I would say once a week I face this, where they want me to do something I'm very uncomfortable with. And I'm like, no, that's not the direction we're heading. But they read about this stuff and they have ideas. And you do have to say no.
Yeah, and what I learned, when I was in training, was it takes a full year of practice just to be able to say no. It's just like the hardest thing to do. And sometimes, and to say no while retaining your relationship, I think that's a trained skill. I'm not saying palliative clinicians don't have it. I'm just saying addiction clinicians really work on it hard. That's our wheelhouse. And so anyways, that's just an editorial. Take it for what it's worth. Every clinician's different, of course. Yolanda responded. And Yolanda, I really feel like not seeing an opioid use disorder patient at the end of life because of their diagnosis it's really unfortunate. And it's really something to think about, like, how can we work better to serve these patients? So I'm really sorry to hear that that's happening. And I'm not really in a position to fix it, but I know there are palliative care colleagues at Hennepin who, if they could collaboratively discuss their practices caring for people with addictions at end of life, I'd be happy to try to coordinate a conversation if you want to reach out to me offline between your palliative care team and my palliative care team. I'm volunteering them for this, but I think it's a worthy to at least try to make a connection, because I think that's what you're describing is troublesome. Okay. So, and then I got one other kind of provocative question. So let's say a normal person without a substance use disorder, without opioid use disorder, has metastatic cancer and is making a choice about their care. And you are offering them hospice or end-of-life care, palliative care, and not life-prolonging treatment versus life-prolonging treatment. You're trying to counsel them on, what do you want to do here? You've got this metastatic cancer, you've got a lot of symptoms, you've got to make a personal choice: chemotherapy, life-prolonging treatment, or end-of-life care, hospice care, palliative care. And I know that's a simplification and there's a lot of overlap between those two, but let's just go with me there. And let's say you have a way of talking through that with the 95% of patients that you normally see. Would you alter how you counsel your patient if it's an opioid use disorder patient with metastatic terminal cancer and they're making the decision between life-prolonging care and sort of end-of-life care or palliative care, or there's probably better words for this. Would you alter your spiel if the person had opioid use disorder? Does anybody want to give an opinion about that? Would you alter your spiel, or just give everybody the same language? And while you're thinking of your answer, another way of saying it, is there anything in your normal spiel that might be a problem for people with opioid use disorder? Let me put it that way. That's a more direct question. Is there anything that you normally say to patients who are considering hospice that might be a problem if you say it to opioid use disorder patients? Or would you just tell them, this is kind of a read my mind. So Abby's saying she hopes she doesn't approach them differently. I will tell you one thing that I do differently and what my concern is. And because this is a little bit of a read my mind question. We got another. Yeah. So it's about the opioids and about the doses of opioids that are required. So, yeah. So here's my thing, and I have seen this a couple times. People with opioid use disorder, as soon as they hear, oh, if I enter hospice, I get all the opioids I want, no one will question me. So I have terminal, I've got a life-limiting illness. I'm going to die from this cancer one way or the other. And I'm choosing between chemotherapy and life-prolonging care and unlimited opioids. And I have opioid use disorder, especially if my opioid use disorder is untreated. That person's going to have a hard time making a decision for themselves. They're really going to be drawn to the unlimited opioids, even if their value system would have them take the chemotherapy and the life-prolonging care. So, and this is particularly untreated opioid use disorder. So when I talk about end-of-life care with someone with opioid use disorder, I am really careful about how I discuss opioids. So before I even talk about opioids, and maybe this is just normal for palliative care for everyone, but before I talk about opioids, before I talk about pain control, I want to talk about values and hopes. What do you want? How do you see you and this disease? Do you want to fight it, or do you want to fight the symptoms, or do you want to prolong your life? What do you want to do? What's your hopes? What's your values? Never would I ever talk to someone with opioid use disorder about opioid therapy being without constraints. And it goes against, at least historically, what some things that used to happen in hospice, and maybe still to some extent need to happen at the end of life. And I would make sure that they know that palliation is part of either course. Pain control is part of whatever decision you make. So it's not like this pathway is mega opioids pain control, and that pathway is no opioids and pain. If one, you can't establish that dynamic. And then the ideal is that you actually don't even have them make this decision until that they're somewhat stabilized from their addiction point of view. Get them on methadone or Suboxone first, get them out of withdrawal, get them out of the cycles of drug use, and then try to have this conversation. Usually the conversation can wait a week, and in that week you can really get the person stabilized, and then they won't be thinking with like the opioid hungry brain. They'll be thinking with their own brain. So that's kind of my editorial. Okay, so we got a couple more messages. Yeah, so thank you from the Palliative folks saying they don't really talk about unlimited opioids. Quality life versus length of life is more the sort of talking points. And then if OUD is undiagnosed and they have a life-limiting illness, then you have to get the diagnosis. That's a great point, Sarah. Thank you for making that point. I don't really address that, but that's a super good point. So is it even really to expect someone who could not cope with life without? Right. So Valerie, explain what that's a, like, I can tell it's like a super deep thought. I'm trying to like understand it. So I love your first comment. People with addictions do usually have some healthy coping skills. I think that's what you're saying, and I agree. So is it realistic to expect someone who could not cope with life without substance use to be able to cope with death without it? No, and I don't think we're saying that they shouldn't get opioids. I mean, they should get opioids, and it will be a coping mechanism. And I think the treating clinician has got to be like very flexible on that, and not to be absolute or rigid or puritanical about opioids. But I also think framing the decision might need to be about their wishes first, and just not feel like opioids are being dangled with one choice more so than the other choice. That was all I was trying to say, is just to really be conscious. And I think people with opioid use disorder listen very carefully and think, thank you, Valerie. Okay, I think people with opioid use disorder listen to these things very carefully. Okay, I think I got through most of my audience participation questions. I think to the question Sarah made, which is really good, I think a lot of people will fly under your radar and you won't realize they have opioid use disorder. So just to really not stereotype opioid use disorder as they may be entering the palliative care context, because they may look like anything. They may talk like anyone. They may, you might be surprised. And to that point, I wanted to just say, like, it is a fact that people in their 80s use less drugs. That's a fact. However, is that because of their age? And I really strongly do not think it's because of their age. I think it's because of their generation. And some of you have heard me say this before. The first generation of Americans heavily exposed to drugs other than alcohol are the baby boomers. And then every generation since. So basically the Vietnam era of generation were exposed to drugs, or the Woodstock generation, if you prefer, were exposed to drugs. And every other generation since then have been exposed. But my parents' generation, the silent generation, had very low exposure to drugs other than alcohol. And so rates of even cannabis use rates are very low in my parents' generation, and then all other drugs as well. So we get this idea that 80-year-olds don't use drugs. That's because of the generations we were caring for. But here comes the baby boomers. And when the baby boomers age into life-limiting illnesses, it is going to fundamentally change palliative care, because they just have a whole different set of circumstances in their life, and they're carrying those with them into older age and into illness. And I just think I think it already is. And I think it is going to dramatically change how we see some of the interactions between addiction and palliative care will not be optional as the baby boom generation ages into life-limiting diseases. So I mean, that's my prediction. I don't think that as the boomers age, they'll suddenly, get sober as they enter their 80s. I think and I will just observe that, like, my one observation that I have is in the Hmong population that are refugees, they don't have American generations. Like, they're not like, there's no baby boomer generation for the Hmong people because they were in Vietnam and they had a whole different set of environmental situations and cultural situations. So the silent generation and the greatest generation, those are American generations. They're not Hmong generations. In our Hmong clinic, we have 100-year-old Hmong patients who are still eating opium. There are elderly people still using opioids illicitly in that community because that is how that community was exposed to opioids over time in Southeast Asia before, and then they brought those with them here. So, and they didn't age out of those diseases. The other thing that's I think is going to be a big factor is that the first wave of the opioid epidemic from 95 to 2005 was pharmaceutical opioids. And I know it's like ancient history, but a huge number of Americans were exposed to opioids. 10% of Americans were taking chronic opioids during that time. And we've detoxed a lot of these people. 1% got addicted, 10% were chronically on opioids, and 40% of us per year got a prescription of opioids. A huge number of Americans were exposed to opioids in that era. And those were, it happened to everyone, but were disproportionately Medicare. And those were folks that were, late midlife, and they're aging. And so there is a huge population of opioid exposed Americans that are entering the end of life. So even if they're not addicted, they've been opioid exposed at some point in their life. And that may have its own complications. People have heard me talking about this before, and this is something someone mentioned, maybe it was Sarah, about suffering. This is how I see it. There's on the top what, I don't know, internists like me, maybe family medicine docs, traditionally think of as like real pain, nociceptive pain, tissue injury, neuropathic pain. I think we kind of have a sense of what that is and how we are supposed to treat that. So those are causes of pain, nociceptive and neuropathic pain. And then in the lower right, anxiety, grief, and mood. I mean, I believe they can cause pain on their own. If you look at the diagnosis of anxiety disorders, headaches and stomach aches are criteria for anxiety disorders in the DSM. But separately, they can also amplify pain. And that might be nociplastic, I think is the term a lot of people are using in terms of sensitizing the brain to pain signals. So the lower right would be anxiety, mood, and grief. And the lower left is like addiction pain. People who are addicted to opioids experience it as pain, but what it could be is craving for opioids. It could be dysphoria. It could be opioids are wearing off and they're in withdrawal. So you have people who are opioid exposed or opioid addicted in the lower left. You have people who are grieving for any reason or have mental illness in the lower right. And you have people with tissue injury and nerve pain in the top. And it's usually someone at the end of life often has diseases that at least the top and the lower right. And then if they have a substance use disorder, they've got the lower left as well. So you've got all this complicated dynamic. And what they know is I'm in pain and I'm suffering. And opioids zap the pain. That's what they know. I mean, I don't want to simplify it. They are often way more sophisticated than that. But the experience may be hard for them to even articulate what's happening, but they understand that they're suffering They understand that it's being experienced as pain. They understand that that they're sick, and they understand that opioids make them feel better. But I think I think a lot of palliative care clinicians are somewhat comfortable balancing the top with the lower right and kind of walking that line between the grief and the mood and the anxiety and the depression, and then also the pain that the cancer is causing and the nerve pain and the tissue and the metastases. But I think adding the lower left creates a complexity. And we should be thinking about, when you report pain, this could be craving. This could be withdrawal. This could be dysphoria. This could be an addiction phenomenon exacerbating this pain. And then,
hey, Charlie, this is Craig Youthy. You mind if I add a little comment that kind of ties into last week?
Love it. Yeah.
Craig Youthy from Stanford and the University of South Dakota School of Medicine. One thing that we have identified is when putting the DSM-5 criteria to that opioid use disorder, many patients are on high doses of opioids, MMEs. They have a single prescriber, and if they weren't getting the high amount of drugs they were getting, the diagnosis would actually not be just opioid dependence. It would be opioid use disorder, because they're going to have the cravings and the withdrawals. And so that's one of the things we find as a challenge is we as prescribers, are we treating their pain but not identifying the underlying opioid use disorder correctly? And I think it fits perfect. I love this Venn diagram because it fits into that craving, dysphoria, withdrawal. And those patients aren't necessarily feeling it because they're saying, I need more meds, doc, and the doc gives them more meds.
Yeah. I mean, I thank you. And I mean, I don't have a perfect answer for that, but I do suggest that we can not always, but we can sometimes sense by the description and location of the pain and what's known about the disease, whether this is the action of bony mets. We have a pretty good sense of what neuropathic pain presents as. So we can start checking these boxes. Someone says they're in pain and we're deciding what to do with the opioids. We can and then we can kind of see whether, is this pain worse with mood? Does it track with your mood? Or does it not really track with your mood? And sometimes it does and sometimes it doesn't. Are you grieving something else? Did you just get more bad news? Did you just have a bad interaction with your family? And now your pain is worse. And that really helps this. And then there are sort of some clues about these, like time to last opioid. If your pain happens predictably after a certain period from the time to last opioid, or accompanying GI symptoms, of course, suggests withdrawal. Some of these craving things, it could be, I mean, sometimes some mental cravings are manifest different from like the experience of physical pain, distractibility, things like that. So I try as best I can when giving high dose opioids to these folks that are in pain to still tease out when the pain is happening, under what circumstances, and does that give me any clue whether it's affect related, addiction related, or tissue damage related. I try, but you're right. Sometimes it's really hard to know that they have an OUD until their opioids get lowered. But so I don't know if I answered or responded to your question, but I think that's great. So I'm going to, just for the purposes of time, this is kind of what I was saying, like a really careful history of the pain and the timing of the pain and the effects that opioids have on the pain. That also gives you a clue about some of the addiction related things. If it's withdrawal, giving opioids back to the person has like a very profound, immediate effect. Whereas if it's cancer pain, it's not like giving them opioids makes all the cancer pain go away. Or it would take a much higher dose. And being aware of the stability of the opioid receptor system is going to really help you eliminate that left lower quadrant, the addiction quadrant. Having them on a little buprenorphine or methadone in the background ideally can help them sort of stabilize some of that, normalizing the role of mental health care. And it's just like every day I have to keep getting better at practicing how I talk about mental health in pain, mental health in addiction, because I use stigmatizing words still, I'm sure. But eliminating that stigma and normalizing the role of mental health in pain care is super important. It's really important to let patients define their own goal. So what is function? We always think about function in pain. Well, what does function mean at the end of your life? And it's just like, we have to kind of step outside of our narrow view of what function means in pain and redefine what function means to this individual in front of me and optimize their function. And it might still be just staying in bed all the time and being awake 4 hours a day. That might be function for them. But let's at least establish what function we're trying to optimize and then titrate our goal to that function. Because normally with pain, we're trying to not let opioids interfere with your physical therapy or whatever. Well, that's not going to happen here. It's going to be different here. But I do still think the idea of optimizing function is valuable as long as you make it patient-centered. And then,
Charlie,
go.
I think you probably have done the same thing as me, I'm guessing. I mean, in the past, when I did more of this, it is really about optimizing them able to talk to their family, right? That, especially if they're bedbound, you don't want them sleeping the whole time.
Yeah.
Because visitors are coming.
Yeah.
People are coming to say goodbye, right?
Yeah. Well, I want to talk about family later, but I think that is probably one of the most important things for most of the patients. I think that is their most important function. And that may only be a couple hours a day. And so a lot of your opioid dosing, and I'm sure palliative care teams are probably all over this, is strategically creating windows of opportunity for meaningful function, and then letting them be comfortable after that. But if they have opioid use disorder, they may have a hard time adhering to that plan. And so how do we help them adhere to their plan to execute these, family conversations if that's their wish? And then also, I do think there's still, because this is still such an area of unknown, trusting your instincts. I think, you all know this. This was more directed towards palliative care teams when I wrote this slide, but it is really just a constant effort to avoid stigmatizing words. But especially if you are the palliative care clinician, right now we have in our hospital a patient with sickle disease having a sickle flare who is refusing opioids because something pissed him off. And I bet he's in the right, but someone did something along the way to make him feel like an outsider. And now he's literally down there suffering because someone said the wrong combination of words or something happened. It might have been a nurse. It might have been a doctor. I don't know what happened. And what you don't want is someone with opioid use disorder, substance use disorder. Their palliative care team is the most important team for them. And it's just really important to be careful about language because you say the wrong thing to these folks and they'll just be like, see ya. I've dealt with too many judgmental people in my life to deal with another person. I don't want to talk to you. They'll kick you out. I mean, I've been kicked out. I don't know, Kurt, how many rooms you've been kicked out of. You do this long enough, you get kicked out of rooms once in a while. But it's just super important to be careful about language. And that is something we're always working on all the time. And then in terms of populations, I will say working in the county hospital, we have a high proportion of African-Americans here. African-Americans have a legitimate concern that they are not going to be offered equal care at the end of life. And I don't want to, I'm not trying to make a sweeping statement about every person in that demographic, but that is something that we've had to be very sensitive to, is that there are certain cultural groups that have less trust in the decisions that are being made with them at the end of life. And I think my guess is that someone with opioid use disorder, substance use disorder, who's making decisions about what kind of care they're going to receive is going to be very sensitive to this doctor doesn't care if I live or die. This doctor just wants me to go away. And that can cloud that distrust in how the message is delivered and the trust between the clinician who's counseling the patient and the patient who hasn't had trust in the system and who hasn't necessarily been served by a system. How do we make them, because hospice might be the option they want, but they won't take it if they're afraid they're being pushed that way because the doctor is giving up on them. And so how do we let them feel like the decision comes from them and not projected upon them by us doctors who have been, causing them problems their whole life? So we talked about function. I definitely want to keep going. Couple more issues I definitely want to hit on. People who are already engaged in the recovery community. I think one really common, in my opinion, error that happens in hospice is that hospice sometimes thinks they don't really need, they're sick, they're dying, they're in pain. Well, they don't need to go to their groups anymore. I mean, they don't need to go to that I think should be 100% up to the patient, and be careful about your language when you propose that. In a very open-ended way, ask them if they want it. Because for many people, this is their community. This is the people that have lived a similar life to them. And we have patients that are like actively dying and still want to come to the methadone clinic because they've been working with the same counselor for 10 years. And they hang out in the lobby and talk to their friends, and their friends hug them and cry with them in the lobby of the methadone clinic. I kid you not. And we'll talk to them and say, your hospice team will take over the methadone. You don't need to come in anymore. And they'll say, I want to come in. This is my community. And this is when I was down on my luck. This is the community that stuck by me. And so don't underestimate the value of the recovery community to the individual, and really ask that even towards the end. This may be their family. And then under-treating pain is a huge issue. It's a whole talk. It's a huge issue that you start overthinking. I think we can both over-treat, give them too many opioids with no constraints and that cause problems. And we can also under-treat because we're so nervous of causing problems. And then they've got cancer pain. So I think it's a really, really individualized, careful decision on both over-treating and under-treating. Buprenorphine and methadone are both compatible with end-of-life treatment of pain. Methadone's maybe a little easier, but buprenorphine is 100% compatible. And our palliative care team now is just viewing it as a compatible thing. And to really try to optimize both together. And both together, both will do better. One or the other, things aren't going to go well. So especially with opioid use disorder, but also for alcohol use disorder, trying to always continue to engage is my opinion as much as possible. I really want to get to this thing about families. The one thing I would just say, be careful when you just stop the Suboxone, stop the methadone. We'll take over all the opioids, no problem. Be careful about that, because that might be more than you're at. It's not always that simple. And the buprenorphine, once stopped, can be a bit of a pain to restart. And sometimes people become unstable in these transitions. So I would just be very circumspect, be collaborative before stopping, and just be careful about making that promise to the patient. But I got to get to the family thing. Okay, families. This is the last thing I definitely want to talk about. A huge deal at the end of life, as Kurt was mentioning. So much about what my parents are dealing with now is family. Right? That's the most important thing to them besides their own day-to-day existence, is thinking about their family at this point in their life. However, part of the definition of addiction is that the addictions cause issues with your relationships. And also, addictions are heritable. So many family members themselves have addiction. And also, there's a lot of trauma in people who have addiction. And a lot of that trauma comes from families. So when you're dealing with someone with an addiction, you just have to really be careful how you bring the family in, and don't make any assumptions about what they want. The family could be very unhealthy. That family could be waiting for that grandma to die so they can take all the opioids. They could be taking the opioids already. I have patients who've done this. It's just, you gotta be careful. So, and the patient may have really, really deep trauma. And I think in end of life with someone with addiction, really giving them opportunities in a safe way to debrief on what they want from their family at the end of life, because they may really want to unpack some trauma with their family, and they may not want to go anywhere near their family. And I'm not going to judge that, but it's more likely to be fraught than it is with someone without an addiction. So just be really careful bringing family in. Yesterday I did a consult. I am continually surprised at how you think it's going to be no big deal, and you ask the family to leave the room, and you're really glad you asked the family to leave the room, even though you think you'd rather keep the family in the room. Just don't make any assumptions about what the patient wishes or wants for their family or what their experience is. And opioids at home is a thorny issue for people with opioid use disorder, not just for them, but also for everyone else in the home. How do you keep those opioids in the right hand? And after they pass away, what do you do with the opioids? And I don't think I've ever heard anyone have an easy solution for this, but it is just a thorny issue. And you got to give them opioids, and the nature of hospice means there might need to be a little bit of a stash of opioids at home for them. But those could go into the wrong people's bodies, and they could also end up in the wrong place after the death of the individual. So it's just, as much as you can find the appropriate person in the home to keep an eye on them, that's ideal, but you can't even always do that. So I'm just going to stop there because we're running out of time. I don't know about you all, but I had a lot of fun hearing from you all, and I really appreciate everyone's input. And this was an editorial, so you should definitely take it in that light and not as if you have different practice. I welcome that feedback. So I'll stop there. And Kurt, if you want to.
Yeah, there was actually another thing in the chat about speaking about federal regulations of methadone for hospice.
Yeah, so by rule, methadone patients need to have an observed dose to stay enrolled every 30 days. So usually that means coming to clinic and getting an observed dose in clinic every 30 days. They can get takeouts would be based on the clinic's assessment of the safety of the takeout. So if there's a lot of risk at home, they're not going to give 30 days of methadone if there's living with a bunch of people who've stolen their methadone previously. So the clinic has to be safe with the takeouts to make sure they don't get diverted, but can give up to 30 days between observed doses. If the patient just isn't present in the methadone clinic, they have a 30-day window before they're supposed to be discharged. If they're just no-show for 30 days. If they are in a hospital, that's different. But currently, and there was a request for the DEA to change this. The DEA has not yet changed this. Currently, facilities like nursing facilities and hospice centers that aren't a hospital, but a standalone hospice center, do not count as guest dosing. So currently, if they're in a nursing home or a hospice center, they're on the clock 30 days, and they need to be in within 30 days. So that is a hindrance. And what usually happens with us is when they're no longer able to physically come, that's when time to switch to methadone prescribed by the palliative care team.
There's another little thing from Sarah there. I don't know if you want to quick read that.
Universal screening for all. Great. Yeah. And then cancer survivorship is such an incredible point because, we probably, and HIV survivorship is like the little sibling of cancer survivorship, is the same phenomenon. We used to give all these opioids to these folks with these diseases, and now they're surviving, which is awesome, but they have the legacy of the opioid exposure. So opioid screening for all, and I think the best you can approaching that screening with, we see a lot of patients on the street using fentanyl. This might not look like that. This might look like something different. This might look like someone who had what they thought was a terminal illness, was started on opioids, and now the HIV provider or the cancer doctor realizes, I'm over my head, I don't want to do this anymore. That might not look anything like your stereotype of addiction. So you should be screening for opioid use disorder, but you really have to take away the preconceived notions of how that might look. Go back to the criteria and try to forget your clinical experience. Any other thoughts or comments?
Charlie, I've had a number of interesting patients, actually 3 people with opioid use disorder who also had needed a kidney transplant. And this is, in a way, their care was palliative, because there was no way they were going to ever make it. There's a requirement to make it a year before you can get kidneys. And there was no way that we were ever going to get there. But now you put something in their arm that they can inject into, and none of those patients is alive. And it's an interesting thing where we think we're doing the right treatment for somebody to get them to the finish line, but in a way, every time that's happened, it's caused the death of the patients that I've taken care of.
Getting that. Maybe a peritoneal dialysis would be better. We have one methadone patient who's on hemodialysis who is still using, luckily he's a snorter and not an injector. So we have never had, so he's actually done well. But he has a fistula and he's snorting drugs still somewhat, but overall he's pretty stable. I recently heard that buprenorphine is removed by dialysis. This is off topic. Have you heard that, Kurt?
I have looked and looked and looked, and there are people that say that it is taken off by dialysis. There's people that say it's not. I typically give them an extra dose the day that they have dialysis after.
Yeah.
But I don't know. And my last guy just died, and they all die of these strange infections.
Yeah.
That they're getting.
As they're tampering with their. Yeah. Yeah. Well, any other questions? Any
other thoughts, anybody? Great talk. That was a good editorial. It makes us all think.
Yeah, that really made me think. When you asked what would our conversation look like for a person with an opioid use disorder versus not, I just thought back to, would you still be looking at a PDMP and paying as much attention to that to make sure that the person isn't requesting early refills? Not to be punitive, but just to open up a conversation with the patient. Hey, I see that you're going through your medications. How can we better help you with this? Do you want to talk about this a little bit more? What's going on? Are you having anxiety? All of those types of things. Or like urine drug screens. Can you speak to that a little bit more? What's the right answer for that? And is that a good indicator? Just kind of back to the basics with the safety measures and having the safety conversation with all patients.
I love the safety conversations, the tone of voice you sort of role modeled there. But I think drug screens, it's interesting because my guess is a palliative care clinician would be very uncomfortable asking for a urine drug screen. And I don't feel that it's required. And I never want my patients to feel like it's about their bodily fluids. I need to collect their urine. I never want to get into that. Once it's going down that road, I'm like, we could find another way to get through this. I'm not like an absolutist and you must collect urine drug screens. On the other hand, it's potentially a useful tool. So I think if there's a lot of uncertainty about what is clinically happening and there's a lot of concern and that the patient's own wishes that they've articulated themselves has not been met, and I think it's a tool that could be used diagnostically. But I would also be really careful because I think it's rarely is it 100% required. And especially in this sensitive end of life issue, I would just be really careful about it.
You know, Charlie, Abby,
Give it more. Sorry. I just think of it more so, you talk about diversion and family members potentially using the patient's medications. I had a scenario, my dad was in a hospital and was receiving IV pain medication and was not getting that. And that became uncovered several years later. So I think that's the angle I come from, is just advocating for your patient and making sure that their pain is controlled more so. And I guess that would be the discussion that I would have with the patient, and that I always did when I asked for a urine drug screen in clinic is, this isn't to single anybody out. It's about your safety and making sure that we're taking care of you the best that we possibly can.
If you could normalize it, and actually many patients who've long-term been in addiction treatment probably don't care at all about their urine at this point.
Right.
But methadone patients given urine samples 1,000 times. They just don't even care anymore. So there are a lot of patients who won't care a wink. And if you can normalize it, and it can just be part of monitoring, like a blood pressure or anything else, yeah, I think it's great. I would just approach it with sensitivity, as you pointed out.
There was a little question by Abby, just wondering if in a family practice clinic, which of the, screening tools for OUD you'd feel most comfortable with.
Mayo, I just was talking to Ben Lai, who's he's the opioid stewardship guy at the Mayo Clinic. The Mayo is now using the TAPS tool for all of their outpatients on pharmaceutical opioids. And I have heard other locations that the TAPS is the most validated of the screening tools. So, it's a little less for street, like for fentanyl. But, for fentanyl, you might want to use just a good drug screen that'll catch fentanyl, and use that plus the NIDA, National Institute for Drug Abuse, has a quick screen for drug use. And the USPSTF recommends all adults get screened annually using the NIDA quick screen for drug use. So the NIDA quick screen for drug use, they also have a NIDA quick screen for alcohol use. You cannot do everything that the USPSTF tells you to do. Otherwise all you'd be doing is screening for every disease. But they do recommend screening all adults for drug use and alcohol use. And I would say TAPS for pharmaceutical, and some combination of a fentanyl urine drug screen and NIDA, the NIDA quick screen for non-pharmaceutical. Audit's a good one. The Audit C is another good one for alcohol. Thank you, Abby.
All right. Well, Charlie, as usual, fabulous talk. Really, one of those things we'll all be thinking about for a couple of hours, trying to figure out where we stand on some of this stuff. So Thanks again. Hopefully your day won't be so bad from this point on with all your call.
It's going to be busy, but that's okay. Okay. Thank you.
Thank you.
Right. Thanks everybody for coming. We'll see everybody next week for nutrition and addiction.